So our speaker today is Dr. Jack Brown. We would like to start with a disclaimer on his photo. It's his wedding photo from distant years past, but we couldn't resist. Jack, can you go ahead and advance to the next slide, please? And the next one. There it is. Let me go ahead and introduce Jack Brown properly. Dr. Brown is an assistant professor. You can back up one slide. There it is. Dr. Brown is an assistant professor of pharmacy, medicine, and public health at the State University of New York at Buffalo. He received his Doctor of Pharmacy degree from the Philadelphia College of Pharmacy and subsequently completed his pharmacy practice and infectious disease specialty residences at the Ohio State University Medical Center. He then took a position at Dartmouth Hitchcock Medical Center and Dartmouth Medical College as an infectious disease specialist and medical school faculty member. During his time there, Dr. Brown obtained a master's degree in epidemiology and biometrics from Dartmouth College. After years of clinical practice and research at Dartmouth, Dr. Brown accepted a position as scientific director with Cubist Pharmaceuticals. During his time with Cubist, he was involved in the daptomycin investigator-initiated grants program and several independent clinical and economic studies of daptomycin. In 2008, Dr. Brown accepted his current faculty position at the State University of New York at Buffalo, with a clinical practice site at the University of Rochester Medical Center. Dr. Brown's patient care activities, teaching, and research is focused on infectious diseases, pharmacotherapy, pharmacoepidemiology, and using cutting-edge technologies to enhance clinical outcomes. Dr. Brown has co-authored over 100 abstracts, journal articles, and book chapters on these topics, and has been invited to present his research at seminars, grand rounds, regional, national, and international meetings. We are pleased to have Dr. Brown's time today to share his perspectives on antibiotic stewardship and the utility of early antibiotic susceptibility results in directing targeted therapy for Staphylococcus aureus bloodstream infections. I will now turn the presentation over to Dr. Brown for the remainder of the session. So Dr. Brown?
Thanks, Brian, and I would thank all of you who are tuning in for your time and attention to review a topic that I have found to be very passionate about and have found to be a very important piece of current medical practice. Here are my disclosures. I receive research funding. I have in the past received research funding from Cepheid. I'm on the medical advisory board of this company, Microphage, who's the maker of KeyPath. I have also received research funding from Cubist Pharmaceuticals and Astellas Pharma as well. So my goal for this presentation today is fourfold. First is to understand the goals and benefits of an antibiotic stewardship program or antimicrobial stewardship program. Next is to outline the limitations of current antibiotic therapy in the treatment of Staph aureus infections. Another goal is to summarize the limitations of standard culture and susceptibility testing. And lastly is to appreciate the capabilities of rapid Staph aureus testing methods and their implications for antimicrobial stewardship. When we think about antibiotic stewardship, we first need to break down the word stewardship, one who administers as an agent of another, which means that as a steward, I am being an advocate, in this case for the patient. If we apply this to antimicrobial stewardship, it's defined by the Infectious Disease Society of America as an activity that promotes the appropriate selection, dosing, and duration of antimicrobial therapy. And as a pharmacist, this really hits very home to me. Appropriate goals for antimicrobial stewardship programs really are threefold. And honestly, the first two are very much in the forefront, and the third one is a distant second. First is combating the element in emergence of resistance. As we know that many different antimicrobials are becoming more resistant, including gram-positives, MRSA, which has been around for years, and now we're starting to see more in the way of gram-negatives and things like Pseudomonas aeruginosa, ESBL pathogens that are running rampant worldwide and through the United States. A second goal, and the second most important goal, is improvement of clinical outcomes for individual patients. So not only applying it in a systematic way, but actually making sure that each individual patient is taken care of and is appropriate dose on their antimicrobials. And a distant third, really honestly, in my mind, and I think any good antimicrobial stewardship program would agree with this, is controlling costs. And we know that many times we have to give more expensive therapies if the outcome is worthy of it. So using new therapies is fine as long as we can achieve the appropriate cost-benefit or cost-effectiveness ratio for different agents, and in this case, different tests. So the question becomes, why antimicrobial stewardship? Well, if you look through the data, and if you work in a hospital, you can see that their misuse of antibiotics is rampant. They're often given when they're not needed. They're continued longer for necessary. I think most antimicrobial stewardship programs do not have a problem giving broad-spectrum antibiotics for somebody who's severely ill. You have to have the intestinal fortitude to be able to discontinue the antibiotics when appropriate. As a pharmacist, I often see drugs that are given at the wrong dose. I also see broad-spectrum agents that are used to treat very susceptible bacteria. Again, narrowing your therapy based on the information you have available to you, I believe, is very, very important, and is one of the cornerstones of a good antimicrobial stewardship program. Lastly, we'll see the wrong antibiotic given to treat an infection. A great example of this is the use of moxifloxacin for the treatment of a urinary tract infection. It's an inappropriate drug simply because it does not get into the urinary tract effectively. One study that sort of highlights this is a Glowacki study. This is actually out of Cook County in Chicago that looked at antibiotic combinations with redundant spectra. Of the roughly 1,200 patients in this point prevalence study, 16% received 2 or more antibiotics that were redundant. And furthermore, 56% of cases overprescribing errors resulted in excessive use of antibiotics. And really the conclusions of this study really that we should consider these cases as not just errors but medication errors, and they should be treated appropriately and accordingly. So when we think about the antimicrobial stewardship team, we should think about it indeed as a team. It's not just one person, it's a team. And we'll go through in the next slide what that team should be made up of. This is a study that came out of Neil Fishman's group at the Hospital University of Pennsylvania in Philadelphia, and looked at 2 major mechanisms for improving the use of antibiotic therapy. First was recommendations made by the antimicrobial management team and they were then compared to ID fellow recommendations from 1993 to 2000 in 180 patients. The outcomes of appropriateness of recommendations, clinical cure rate, and treatment failure were reviewed by a blinded ID physician reviewer. And you can see that the differences between the appropriateness comparing the ID fellows to the antimicrobial management team, there was a significant difference in terms of appropriateness of recommendations, clinical cure rate, and treatment failures. This highlights the importance of the team effect. It's not just one person that should be charged with these activities, but a team of individuals. So who exactly are those teams? The core members of should be a multidisciplinary team that include an infectious disease physician and a clinical pharmacist with infectious disease training who should be compensated for their time. So this shouldn't be like a side activity. This should be part of their job description. With the inclusion of a clinical microbiologist, an IT person, an infection control professional, and the hospital epidemiologist as well. Because antimicrobial stewardship is an important component of patient safety, it really should be considered to be a medical staff function. The program is usually directed by an infectious disease physician or co-coordinated between an infectious disease physician and an ID PharmD with infectious disease trainings. The collaboration between antimicrobial stewardship team and the hospital infection control and pharmacy and therapeutics committee really are very, very important. The support and collaboration between hospital administration, medical staff leadership, and local providers in the development and maintenance of the stewardship program should be essential. It should be the forefront of garnering power and garnering appropriate administrative functions to be able to employ and maintain this program. So what really are the byproducts of a good stewardship program? I think there are a couple. First is better clinical outcomes. And again, this is another study from Neil Fishman's group. I'm going to highlight Neil Fishman's group from the Hospital University of Pennsylvania because they were one of the first folks to actually publish their data in the realm of antimicrobial stewardship. They've done a fine job over the years. In this study, they compared antimicrobial management program, again, to usual practice in terms of outcomes, where outcomes were defined as appropriateness of recommendation, clinical cure rate, and treatment failure. And they were, again, reviewed by a blinded infectious disease physician reviewer. But this time they were reviewed from 2002 to 2005. And what they found that there was a statistically significant difference, again, based on these relative risks and the 95% confidence intervals that you see there, in terms of appropriateness of antibiotic therapy, cure, and failure rate. This highlights these results are not only can be put into place at one specific time, but this difference can be sustainable. And this is evidenced by the two different studies we talked about out of the hospital of the University of Pennsylvania. Next is general clinical effectiveness, and this is a study that was done by Cab Bond from Texas Tech a few years ago. It actually highlights the importance of something that's very close to near and dear to my heart, which is the clinical and economic outcomes of a pharmacist-managed antimicrobial management program where they focus really on aminoglycosides and vancomycin therapy. It was a retrospective review of roughly 200,000 Medicare patients. And they looked at hospitals with and without pharmacist management protocols. And you could see with those who actually had pharmacy management protocols in place and activities that required interventions, there were significant differences in terms of length of stay, total Medicare charges, hearing loss, renal impairment, and even death rates. So basically, when pharmacists manage aminoglycosides and vancomycin, people die less often, which I think is part of a good antimicrobial stewardship program. Next is the reduction of infections caused by antibiotics. And this is another meaningful byproduct of an antimicrobial stewardship program. This is a study that comes out of Quebec, Canada, where they had in 2003 a epidemic of NAP1 strain CDAD, where they used a series of approaches to attempt to control the epidemic. They first employed infection control measures, and you can see that where it started in September of 2003, and they found little in the way of results, meaningful results in terms of reduction of Clostridium difficile associated disease. When they implemented their stewardship program, you can see based on this graph here, starting in April 1st of 2004, they saw overall a 60% reduction in CDAD from years 2003 to 2004 to 2005 to 2006. So not only are we talking about cost reductions and better outcomes, we're also talking about the impact of future resistant organisms. What about costs? This is a study that was where the aim was to test the hypothesis that antibiotics could be used to control or be improved in a community teaching hospital with their improvements in reductions of overall costs and antimicrobial resistance. This is an interventional study with historical comparisons or historical controls in a large community hospital in Dallas, Texas, where their interventions included conversion from IV to PO in highly bioavailable antimicrobials, discontinuation of perioperative antibiotics within 24 hours for patients undergoing clean and contaminated surgeries, consultation with an infectious disease physician for antimicrobials requiring therapy greater than 48 hours. And these data were analyzed after the first 33 months. Patient outcomes were reviewed during the hospital stay and readmission if they recurred within 30 days of discharge. What they found is from April 2001 through December 2003, a total of roughly 1,400 patient requests for antimicrobial therapy were intervened on. The overall physician compliance was actually very good in the 90 percentile range. And what they found that their antimicrobial cost per patient day decreased by 31% from $13.67 per patient day to roughly $9.4 per patient day. Now, if we aggregate this over that total time period, it's a cost savings of upwards of $1.8 million over that 3-year period. A collateral effect that isn't mentioned on the slide is they also saw a reduction in numerous drugs, drug-resistant Pseudomonas, Klebsiella pneumonia, where they also saw a reduction in Clostridium difficile-associated disease as well. So let's talk a little bit about that. This is another study out of Boston, a small urban hospital in Boston, where they evaluated the impact of interventional multidisciplinary antimicrobial management program on the incidence of nosocomial infections caused by resistant Enterobacteriaceae, really longitudinally over a 7-year period. They focused on minimization of inappropriate use of third-generation cephalosporins. Following the implementation of the program, there was a 22% decrease in the use of parenteral broad-spectrum antibiotics, including third-generation cephalosporins, despite a 15% increase in acuity of patients during that time period. So patients got sicker, but the resistant bugs actually were less. This program found that there was a statistically significant decrease in the number of infections caused by resistant Enterobacteriaceae. They also found, incidentally, decreases in their MRSA rates and their VRE rates. So implementing a good antimicrobial stewardship program not only can impact outcomes and the potential for resistance, but also can save money as well. So let's look at an example here. The example we'll take a look at is Staph aureus bacteremia. This is a study coming out of that comes out of Chicago in the mid to late 90s, looking at the amount of vancomycin used at a specific institution and the development of VRE within that institution over a specific time period. And you can see it tracks the element of VRE, the incidence of VRE, tracks very nicely with the tonnage of antibiotics used over that time, suggesting that we really need to scrutinize our vancomycin use because it really can drive resistance in many cases. So let's talk a little bit about appropriate therapy for Staph aureus bacteremia. Now, I round every day at the University of Rochester Medical Center. For somebody who has a Staph aureus bacteremia, so gram-positive cocci clusters, they're going to be empirically started on vancomycin, so they can cover MRSA and MSSA. But if you really take a deep dive into the literature, vancomycin is really not a preferred agent for MSSA. And if you look even deeper, worse outcomes are noted when vancomycin is used compared to semisynthetic penicillins and cefazolin, or first-generation cephalosporins. This is evident not only in terms of efficacy, which I think that there's an outstanding amount of literature, but actually there's very good emerging data suggesting that there's definitely a toxicity differential as well. A study that's going to be presented at ICAC this year in about 2 weeks from our group at the University of Rochester Medical Center has shown that 12% of patients who are exposed greater than or equal to 48 hours of vancomycin have some element of nephrotoxicity. And going even further with that, of the 400 patients that we studied, 4% actually went on to have hemodialysis. So we're not talking about a trivial renal effect here. We're talking about something that actually can potentially put patients on hemodialysis. So patients with documented MSSA really should receive semisynthetic penicillins or first-generation cephalosporins without a doubt, not only for the element of efficacy, but the element of toxicity as well. So what about the untold story of mortality? And this is data that we took from literature when we put together our decision analysis that we'll talk about in a few slides from now. And when we queried the literature in 2010, we looked at, okay, what's the mortality associated with patients who have MRSA, right, who are empirically started on semisynthetic penicillins and are switched to vancomycin. And the literature estimates are somewhere in the neighborhood of 59%. That's why we start very broadly, because we don't know whether patients actually have MSSA or MRSA. So what about patients who have MRSA who are empirically started on vancomycin treatment? Turns out that about a third of them will actually go on to die. How about MSSA? So if we had a crystal ball and we could start patients on semisynthetic penicillins for MSSA bacteremia, if we knew in some way that they had bacteremia was due to MSSA, their mortality would likely be 12%. Now compare that to our dogma, what we do nowadays, where we start patients on empiric vancomycin and then switch them to semisynthetic penicillins. The mortality is somewhere in the neighborhood of double that, or 23%. There's really, and I believe this story of MSSA in its empiric treatment with vancomycin, the potential benefit in mortality and other meaningful outcomes really is a story that really isn't very well told and really really isn't well told in terms of clinical practice. So there are a variety of different studies that have gone on to take a look at this in a variety of different ways. The first one was on the top there is out of the Duke, of the folks from Duke, who looked at the use of vancomycin or first-generation cephalosporins for the treatment of hemodialysis-dependent MSSA. What they did was during a 84-month period, 123 dialysis patients with MSSA bacteremia were identified. The two groups were similar in terms of their Apache 2 score, comorbidities, source of infection, and hemodialysis access. What they found was treatment failures were more common among patients with vancomycin, and i.e. you could see the numbers there, 31% versus 13%. And what they went on to do is do a multivariate analysis, and factors that were independently and i.e. statistically associated with the treatment failure were exposure to vancomycin. So vancomycin, in this case, really as compared to semisynthetic penicillins or first-generation cephalosporins in this case, really the patients did much worse. Another good study was from Tom Lodis before he went to Albany when he was in Michigan in the early 2000s. The objective of this study was to determine the effect of delayed therapy on morbidity and mortality associated with nosocomial Staph aureus bacteremia. The study included all episodes of Staph aureus bacteremia developed greater than or equal to 48 hours after hospital admissions. What they did is used a classification and regression tree analysis, or those of us who use these statistics, which we also call them a CART, to find a breakpoint between mortality and early and delayed treatment. And what they found is during the 25-month study period, 167 patients met the inclusion criteria. His analysis showed that delayed treatment was found to be an independent predictor of infection-related mortality. And you can see the difference in terms of mortality there on the screen. It was significant. There was also a statistically significant longer length of stay. So, what are the challenges? Well, the challenges really, first of all, are recognizing the need for rapid therapy optimization. Many hospitals really dogmatically treat all gram-positive cocci clusters from blood basically the same. Start off with initial vancomycin therapy, then 3 to 4 days later, as we'll discuss in a moment, they'll put them on narrowed therapy with semisynthetic penicillin or first-generation cephalosporins 3 to 4 days later. Second is the high level of resistance. There's often suboptimal therapy for MSSA patients, is less likely infected with therapy with MRSA patients. Well, let's think about this a different way. Improving a facility's MRSA rates has really been the focus of a lot of patients instead of actually trying to treat patients who have MSSA infections and optimizing their therapy. One way that we can achieve this outcome is the timely determination of susceptibility up front. And really one of the key challenges is, even if we get this information, I'm going to mention this several times throughout my presentation, is reporting this information. If we can get it as soon as hours after getting the information, we need to make sure that we communicate that to the end user, i.e. the clinician, to be able to incorporate that into a patient's antibiotic regimen. So timely communication of the information I think is crucial. So this slide, I've outlined a few studies that have used rapid testing to reduce the length of stay and subsequent hospital costs. The first one was Nguyen and colleagues from Stanford who performed a retrospective study of patients to identify patients infected with MSSA. These are all patients infected with MSSA who were receiving vancomycin therapy when susceptibility results were available. Vancomycin treatment and length of hospitalization were compared in these patients for a 6-month period before and after the implementation of rapid testing. Among the 65 patients and 95 patients identified before and after testing, vancomycin usage declined from a median of 3 days to 1 day. Patient hospitalization days also declined from a median of 8 days to 5 days. Another study that has highlighted this was Carrie Bauer and Deb Goff from Ohio State, which happens to be where one of the places I trained. They performed a similar study, but this time they solely looked at Staph aureus bacteremia, so it wasn't all comers in terms of Staph aureus. They found that mean time to switch from empiric vancomycin to cefazolin or nafcillin in patients with methicillin susceptible Staph aureus was 1.7 days shorter. They also found that during the rapid testing phase, the mean length of stay was 6.2 days shorter, which is massive, and a mean hospital cost savings of over $21,000. So this not only reduces the length of stay, but actually reduces the cost. So this slide here is taken from a manuscript that one of my residents and I have in press at AGHP. It really highlights the time it takes to put a patient on the appropriate targeted therapy. Traditional culture and susceptibility measures really don't allow us to optimize therapy until 3 to 4 days later after our gram stain is available. Now, if we were to compare this to the next slide, if we can get information, we have the ability to get information now. Within the first day, we can actually save 2 to 3 days of suboptimal therapy and increase the time on targeted antimicrobial therapy. In this case, we could identify MSSA and put a patient on semi-synthetic penicillins or first-generation cephalosporins quicker, which we believe will reduce mortality, increase success rates, and reduce costs. So this is a study that our group in Buffalo did about 5 years ago, and the aim was to evaluate the effect of rapid testing on mortality and economics compared to traditional empiric therapy used in the literature-derived decision model. We found the absolute mortality difference for MRSA prevalence at a very wide range, i.e. 80% to 5%, which I'll show on the next slide, favored rapid testing when compared to empiric vancomycin testing, empiric vancomycin therapy. The graphic here on this slide, though, shows and outlines the traditional approach to treatment of Staph aureus on the top and the use of rapid testing on the bottom. What you find here is that the ability to rapidly identify MRSA allows you to switch to semi-synthetic penicillins earlier, thereby reducing the overall mortality. It's important to note that this strategy's value isn't really with MRSA, but rather with MSSA, by taking advantage of the difference in mortality between vancomycin and semi-synthetic penicillins for the treatment of MSSA. In this model, you see the highlighted sections that substantiate a 10% difference in mortality in MSSA when vancomycin is changed to semi-synthetic penicillins, as opposed to starting on semi-synthetic penicillins starting in the first day. Taking into account the prevalence of MRSA, if we roll back the tree, there's roughly a 7% risk reduction when we employ rapid testing over empiric vancomycin therapy. So the idea here is that this gives us an idea where we can go with this. We can potentially save lives with this. This obviously is a literature-derived decision matrix model, but it gives us some idea of potentially where we can go. I think it's clearly stated that we can actually save money, reduce length of stay, and have more successful treatments. But unfortunately, the studies that will allow us to actually have mortality as a dependent variable in a study, where we can study it, really are elusive due to the number of patients that we would need to study it, which really is cost prohibitive at this point. But this gives us some idea of where we can go. So what about the costs? So I said that we looked at costs between a variety of plausible ranges, and between 5% and 80% of MRSA, which is right in the sweet spot where most hospitals are, 99.9% of hospitals are. You can see in this graphic, using a sensitivity analysis based on the previous study, where vancomycin is more expensive pretty much in all scenarios when it's compared to rapid susceptibility testing. So how do we make the change faster? What we're looking for is a test that can run the same day results and have them back quickly. We want to be able to report those results in some way. We want the end user, the physician, or the pharmacist who's on the antimicrobial stewardship program to be able to actually use them. And the question really becomes, how can we use technology to help us in this effort? One technology platform that's available to us is the use of PCR, the Staph aureus bloodstream infection PCR. This is a powerful technique that's been around for some time that uses amplifying gene technology. Specifically, it uses probes and primers for specific DNA or RNA. It uses the polymerase gene to synthesize complementary sequences of DNA using a number of different subsequent cycles of that DNA to get it to a detectable level. The results are available in a variety of different times based on the platform that you use. The quickest one that at least was commercially available at one time was as quick as 60 minutes. The important thing to note here is that rapid Staph aureus MRSA assays typically target one of two things. They target the bacteria, the species, by looking for a specific gene, such as the SPA gene, the NUC gene, or the FEM gene, or they look for resistance. In this case, for methicillin resistance, which is encoded by the MEK-A SEC-MEK subtype, which gives us results in terms of Staph aureus positive or negative, or MRSA positive or negative. One important caveat with this technology is that there have been a number of different gene mutations that have been reported. Now, I'm not going to go through each one of these case reports in detail, but it's pretty well known that somewhere between 5 and 13% roughly are a percent of tests can have false positive or false negative. It's a possibility. I don't think any test is perfect, but I will tell you that the tests that sort of put using this technology on the map, the Cepia's expert tests, has been plagued by recalls due to these problems with false negatives or false positives. One shortly after they first were launched, and one now that still makes the product unavailable. So it's a point of differentiation that you might want to keep in mind. Again, no test is 100%. In this case with PCR, you want to make sure that you have a phenotypic test to ensure that results are accurate and you don't have false positives or false negatives. So in terms of PCR reports, it really does not report susceptibility. It reports resistance. And the FDA considers this type of testing to require phenotypic susceptibility testing in order to make sure that the accuracy is as high as it should be. Now, with PCR, they don't provide information related to MIC of the pathogen. And as a pharmacist, this is really important information. In particular with vancomycin, we're very interested in, or nafcillin, we're very interested in looking at the MIC because the MIC can really make a difference in terms of the dose we get. For vancomycin, the pharmacodynamic parameter that's associated with success or failure or mortality is one that is driven by area under the curve divided by MIC. And for beta-lactam, such as nafcillin and first-generation cephalosporins, just time above the MIC. So these factors really can make a difference in terms of the approach that we use, because front-loading regimens and being able to maximize that pharmacodynamic parameter has been associated with mortality and associated with differences in clinical outcome. So I think PCR is unable to do this. You'll have to wait the additional 48 hours to wait for traditional culture and susceptibility testing, so you aren't able to hammer them hard as we have proven that it becomes effective here at University of Buffalo. A new technology that's made by Microphage is the BAT technology, or bacteriophage amplification technology. And really what happens here is that it uses bacteriophages, which you may know or may not know is a phage is basically a virus that can infect a bacteria. In this case, we're infecting Staph aureus. And we can use this phage as a surrogate marker for Staph aureus. And these phages can be made to be very, very selective. It can infect, multiply, and rapidly become detectable for certain types of Staph aureus. All right. So the test uses a live organism that enables not a PCR type of result, but more of a phenotypic susceptibility assessment. So this technology actually has the ability to potentially give you an MIC, and we'll talk about that in the next slide. The way the process works is a blood sample is added to a pair of tubes. And one tube, the first tube, is the tube that's actually used for the identification of the species. Is it Staph aureus or not? Which is the one on the left, as you see in this graphic, which is detailed in the ID. On the right, it's the red tube, which is susceptibility testing. This gives you information related to MSSA or MRSA. What happens here is these tubes are incubated, and the phage is actually able to proliferate, and we could detect these two reactions, which are done simultaneously, within 5.5 hours, as we'll see on the next slide. So the card here to the right is also called the detector, and this detector allows us to get two pieces of critical information. As we see on the left here, in the ID section, where it says control and Staph aureus, the bottom line there, if that bottom red line is there on the left, that means that you do indeed have Staph aureus. And the line to the right, if there's a line on the bottom where the line to the right is, if it's within that oval circle there, that means that you are indeed, you do indeed have MRSA as opposed to MSSA. So it's two simultaneous tests that allowed you to screen for Staph aureus and MSSA or MRSA simultaneously. And it's suggested, given the approach here, that if you use if there's no negative, if there's a negative result for Staph aureus, really the MRSA and MSSA susceptibility results probably should be disregarded. You should probably wait for cultured susceptibility testing, because really we're only looking for Staph aureus here. All right. So again, it's FDA cleared by for bloodstream testing to report both MRSA and MSSA. It's not meant to screen for coagulase negative staph or versus Staph aureus. Results are available in as little as 5.5 hours after being taken from the gram stain. Really, it provides phenotypic accuracy and really is not detecting resistance. And what I find most interestingly is that I'm a pharmacist. I'm not really a lab-trained guy. I do have a laboratory, but I'm not a lab guy. And I think that I could probably determine whether a patient has Staph aureus or MRSA or MSSA using this detection method. It requires very little specialty training, and the equipment is very simple to use. So this BAT technology, it's very interesting. I find it fascinating because typically when we think about platforms for technology, we're thinking about large capital expenditures and infrastructure that requires us to not only invest in training a ton of time, but actually a ton of expenditures and space in your lab. But this technology using this detector card, has the potential to do multiple reactions at one time. So for example, you could put together a gram-positive panel with Staph aureus, Enterococcus, and Staph or strep species, and allow you to look at different organisms and different drugs and different MICs. So really you could make a panel out of these, and I think that the company is very interested in approaching these types of situations, because you can not only get rapid MIC testing, you can allow patients to put on the most appropriate, not only the most appropriate drug, but the most appropriate dose, taking advantage again of those pharmacodynamic characteristics. And again, we're not talking about resistance here, we're talking about susceptibility. And we can look at different MICs for different drugs for different bacteria. So really the potential here is limitless to put together different cards for different bacteria that may be pertinent in the clinical setting. For example, you can put together a gram-negative card, a nosocomial gram-negative card where you look for Pseudomonas aeruginosa or ESBLs with different MIC testing. So the potential here is to have a very unique platform with little in the way of capital expenditure or capital infrastructure. Speaking of capital infrastructure, that is one of the most important things we think about when we talk about costs of these tests. It's very easy to get drawn in by the cost of the individual assay, but really we have to think through. Okay, we have an instrument cost too. Usually it's a minimal instrument cost that here are listed here. So these are the minimal instrument costs. The cheapest one here is BD Genome, and you'd have to buy the testing equipment through Cephia now, and that's $25,000. We're thinking about the total cost of a test. We have to not only factor in the cost of the assay, but actually the cost of the instrument as well. And I think that it's very easy to get sucked into cost-effectiveness analysis that only look at direct cost. And what I mean by direct cost here is just the cost of the test, not the infrastructure. This is very analogous to some of the research that I've done in comparative effectiveness for pharmacoeconomics. Really, when we're looking at those types of things, we not only need to look at direct costs, i.e. the cost of the drug, how much it costs the pharmacy to buy it, but actually what happens, so the downstream effects. And in this case, those downstream effects from a testing standpoint are the capital expenditures in terms of the instrument costs. So my point here is to be a well-informed consumer, understand the total cost, not just the cost of the assay. So, rapid testing and antimicrobial stewardship. I believe that the ultimate goal of antimicrobial stewardship is to improve patient outcomes and patient care. And I think Staph aureus is a great example of that because it's common in clinical practice, it has a high mortality rate, and really if you delve into the literature, using vancomycin really is inferior to using some of the synthetic penicillins or first-generation cephalosporins for MSSA infections. And rapid testing, I think, is a really attractive tool that really antimicrobial stewardship programs can employ to take advantage of that difference in terms of outcomes and save money as a consequence. So rapid tests really have the ability to either provide information on species, susceptibility, or both. What you're interested in here is, for me, I would be interested in investing in a platform that actually can build on these characteristics, not just a simple yes, no, is it resistant or not. So rapid testing information needs to be made available to the clinician and the member of the stewardship program really in a timely manner. This is something I really want to drive home. We can get information instantaneously. It's no good if it stays in the microlab. It needs to be articulated to the team in order to make timely changes. Really, there are some considerations potentially within the microlab that one needs to think through. I work with a very astute microbiologist who has real life issues related to sometimes staffing, shifts, and the tests that are available during staffing shortages in the 3 shifts within a 24-hour period, or say on weekends. Sometimes it's hard to get this information out, for example, on a weekend or during the night shift. Really, and those situations at each individual institution really need to be thought through, and protocols and procedures need to be put in place to optimize the reporting of the information. Right? So suffice to say, collaboration, cooperation, communication, I really think between the stakeholders, and those stakeholders are the team members that I mentioned in my first couple of slides, really is crucial to have an effective stewardship program. So in closing, my synthesis of the information I presented, I feel that rapid testing provides results several days quicker than traditional culture and susceptibility methods, which can lead to selection of the most appropriate antibiotic therapy if this information is communicated in a timely manner to the clinician taking care of the patient. I think that antimicrobial stewardship programs will likely benefit from the application of rapid testing if appropriate policies and procedures are in place to communicate this information timely. Again, if this is appropriate technology for your institution, think through the different tests that are available to you. Common tests, again, are PCR and some of the phenotypic tests we talked about, in particular KeyPath. And really, if you get that information, develop policies and procedures to communicate them to the end user. So
Thank you, Dr.
at this point, I'd like to...
Oh, I'm sorry?
At this point, I'm happy to take any questions, brief questions, if anybody has any.
Absolutely. Thank you, Dr. Brown. We do have several questions. Our first question is from Charles. Do you have any studies comparing the efficacy of cefazolin versus nafcillin for MSSA? And is cefazolin a better choice based on a 8-hour versus a 4-hour dosing as well as cost of therapy?
There is some information about that was presented probably about 8 years ago, looking at the differences in terms of cefazolin and nafcillin. There is some suggestion it wasn't statistically significant. I believe that the publication was in CID, saying that nafcillin was probably the most appropriate agent, followed very closely by first-generation cephalosporins, and followed distant third by vancomycin. So there is some data definitely suggesting that first-generation cephalosporins and cefazolin are optimal therapies. Of those two, I think the difference is minimal. I think really what it comes down to is we have some challenges in terms of dosing regimens sometimes with some of the synthetic penicillins that are real-life challenges. In terms of the different durations of the infusion, to my knowledge, there aren't any information outlining that question.
Dr. Brown, our next question comes from Cheryl, and she's asking, are the MSSA study results about the lack of vancomycin efficacy new? Why don't I hear more about this?
These actually are not new. These, if you can, there are at least 4 to 6 papers to date that have outlined significant differences in terms of outcomes in different populations, anywhere from success or failure, where there was statistical significance. We compare vancomycin to semi-synthetic penicillins or first-generation cephalosporins to mortality, and there have been several. Meta-analysis and individual studies that have outlined this. This is not new information. A lot of times what we're dealing here with is dogma and clinical practice that's been institutionalized for years and years and years. I think that with the advent of new technologies such as rapid testing, it allows us to take advantage of this delta in terms of the potential mortality difference, success or failure, and certainly the economics of the situation.
Thank you, Dr. Brown. Our next question is from Shala. The question is, if a MSSA and or MRSA, I'm assuming, is identified with the rapid microphage test, is traditional susceptibility testing still necessary?
The answer to that is yes. In no way should rapid testing outdo traditional culture and susceptibility testing. I think there's the potential for it to really become very close, but I think this technology is something that we can use and we can help us early on in therapy. But I think really culture and susceptibility testing is still the gold standard. These tests will allow us to make changes potentially earlier on, but we still need to do the culture and susceptibility testing, in my mind.
I'll add that the KeyPath test does provide an MSSA or an MRSA result, but does not provide an MIC, so it should be continued for MICs. Our next question is from Dennis. What metrics do you suggest to measure the success of an antibiotic stewardship program, and for a smaller hospital with less means to do those kinds of measurements?
Well, I would urge there are lots of them, and I would urge dentists to look in this month's issue of Pharmacotherapy. Our group published both process and outcomes measures for different antimicrobial stewardship programs. And if you would go to read that paper, they're well articulated. There are plenty of them, and it really depends on what you're looking at. Are you looking at process outcomes? Or are you looking at straight up outcomes? So process measures versus outcomes measures is a very serious question you need to ask yourself. And I would urge you to go to this month's Pharmacotherapy and the special issue looking at stewardship, and we have a nice paper in there outlining our thoughts.
Okay, Dr. Brown, our next question is similar from Jennifer. What ideas do you have on measuring the use of rapid tests in patient care in a hospital? And I suspect this question gets at, how do I know the clinicians are using the test?
Well, I mean, this is a part of the antimicrobial stewardship team. So the clinical microbiologist or the chief of microbiology, usually, at least at our institution, I think in most similar institutions of our size, really are involved in the antimicrobial stewardship program, really have a handle on this. This shouldn't be just a test that is used with blinders on. This shouldn't be something that just the stewardship program or one person within the stewardship program is advocating or using. It should be as with any new test, it should be monitored. It should be reviewed to ensure that it is providing the appropriate information that's going to help you treat patients. So I think that it needs to be thought through if you're considering tests and used in the appropriate situations. Obviously, these tests aren't validated in all sites. That's why I chose to talk particularly about Staph aureus bloodstream infections. So you really need to think through, is it being used appropriately, and you should query your clinical microbiologist to find out whether indeed these tests are being used, and if not, why they're not being used.
Our last question, Dr. Brown, comes from Julie. How do I justify this testing in my hospital?
Well, I think the real question is, how do you not justify this test in your hospital? I think in this presentation I've outlined the 3 main metrics that most folks are really interested in. Really is a potential difference in mortality. We articulated that there's definitely a potential for that. We outlined through a couple of different studies, rapid testing certainly does impact success or failure, and decreased length of stay, and lastly in cost. So we're treating patients better, getting them out of the hospital quicker, and it's saving money. These are one of those few win-wins you find in clinical practice, and I believe a good stewardship program should be using these to their advantage.
Okay, we do have one more question that just came in, and we do have a little bit of time, so I'll ask it. This question is from David. Are there large published studies showing improved outcomes yet with microphage? If so, has this included patients with severe sepsis, compromised hosts, etc.?
Right. To my knowledge, you may be a better person to answer this question, Brian. But to my knowledge, there aren't any large studies that have tackled this question.
No, the test is fairly new. It just began being marketed in January, so those development of those studies is ongoing.
So I don't know if you can talk about if that's one of the priorities for microphage, studying those particular populations or not.
Yes, there are a number of studies that are being commissioned right now to be able to compare outcomes, and those outcomes measurements that will likely be length of stay reductions, times to optimization of therapy for patients with MSSA and MRSA infections, and length of stay in the hospital with some assertions as to cost savings. And if there are listeners on this webinar who would like to discuss participating in such trials, I certainly wouldn't mind hearing from them. And let's see, this is all the time that we have. There were a few extra questions that came in, but I'm sorry we won't be able to get to them. One listener did highlight that the KeyPath test is only approved for Becton Dickinson BACTEC blood culture bottles. And so I'll go ahead and let you know that if you are interested and you use BACT Alert from bioMérieux, clinical trials are now ongoing for clearance of those bottles.
That's exactly right. That testing is underway.
Right. So another general question that's come in is, can I get the presentation? I'd like to let our listeners know that at the end of this and after I aggregate the information from the participation, I will send out this presentation to all of our attendees and those who registered but could not attend. So with that, I'd like to thank you, Dr. Brown, for this informative and educational session. We certainly appreciate it. I would like to thank our audience for their time and attention, and also to let all of the attendees know that we'll send out not only the presentation, but we also intend to publish a link to this presentation which has been recorded. So this concludes the webinar, and on behalf of Dr. Brown, microphage, and critical care patients everywhere, thank you again and have a successful day.